Welcome to this edition of the First Aid Show. What we're going to talk about now are the latest 2015 Resuscitation Council guideline changes. The recommendations on CPR change every 5 years. On the 15th of October 2015, the European Resuscitation Council, ILCOR, and the UK Resuscitation Council announced the 2015 guidelines. Our training courses follow the ERC and UK 2015 recommendations to ensure the latest guidelines are included in our online and classroom courses. When the rules change, it's not that the old rules were wrong, it's that better advice is now available to improve survival rates for a patient and improve the understanding of what to do for the rescuer. There are not as many changes in 2015 as there have been in previous years, but the main changes are as follows. Guidelines 2015 highlight the critical importance of interactions between the emergency medical dispatcher, the bystander who provides CPR, and the timely deployment of an automated external defibrillator or AED. An effective, coordinated community response that draws these elements together is key to improving survival from out-of-hospital cardiac arrest. The emergency medical dispatcher plays an important role in the early diagnosis of cardiac arrest, the provision of a dispatcher-assisted CPR, known as telephone CPR, and the location and dispatch of an AED. The sooner the emergency services are called, the earlier appropriate treatment can be initiated and supported. The knowledge, skills and confidence of bystanders will vary according to the circumstances of the arrest, the level of training and prior experience. The bystander who is trained and able should assist the collapse victim rapidly to determine if the victim is unresponsive and not breathing normally, and then immediately alert the emergency services. Whenever possible, alert the emergency services without leaving the victim. The victim who is unresponsive and not breathing normally is in cardiac arrest and requires CPR. Immediately following cardiac arrest, blood flow to the brain is reduced to virtually zero, which may cause seizure-like episodes that may be confused with epilepsy. Bystanders and emergency medical dispatchers should be suspicious of cardiac arrest in any patient presenting seizures and carefully assess whether the victim is breathing normally. With basic life support, the key messages are: ensure it's safe to approach the victim. Promptly assess the unresponsive victim to determine if they're breathing normally. Be suspicious of cardiac arrest in any patient presenting with seizures and carefully assess whether the victim is breathing normally. For victims who are unresponsive and not breathing normally, dial 999 and ask for an ambulance. If possible, stay with the victim and get someone else to make the emergency call. If possible, stay with the victim while you're calling an ambulance. It's been added to the regulations that if a phone has a speaker facility, switch it to speaker mode. This will facilitate continuous dialogue with the dispatcher, including, if required, CPR instructions. Start CPR and send for an AED as soon as possible, but do not leave the patient to search for an AED. AED units are safe to use even without training, so should always be used if available. If trained and able, combine chest compressions and rescue breaths, otherwise compression-only CPR. If the compressions are too shallow, it's more harmful than compressions that are too deep. Therefore, it's reinforced that compressions should be between 5 to 6 centimeters on the average adult. CPR is difficult and it remains recommended that, if possible, change to a second rescuer after 2 minutes to ensure the quality of compressions. In the 2015 guidelines, the importance of recoil is also reinforced. By allowing complete recoil of the chest after each compression, results are much better of venous return to the heart and may improve the effectiveness of CPR. CPR providers should therefore take care in avoiding leaning forward after each session of compressions. It was also added that mouth-to-tracheostomy ventilations are also an effective way of delivering breaths for somebody with a tube or tracheostoma. Another change was that the maximum interruption in chest compressions to deliver the 2 breaths over 1 second and opening the airway before resuming chest compressions is no more than 10 seconds. With children and infants, we say compress the chest for at least 1/3 the depth of the chest. But how far is this? It's stated now still as 1/3 of the depth of the chest, but it's been clarified that approximately 4 centimetres for an infant and approximately 5 centimetres for an older child. We still use 2 fingers on an infant under 1 year, and we use 1 or 2 hands for a child over 1 year to achieve the adequate depth of compressions. With the breaths and with children and infants, the duration of the delivery of the breath is stated as about 1 second to coincide with adult practice. If an AED arrives, switch it on and follow the instructions. Minimise interruptions to CPR when attaching the AED pad to the victim. Do not stop CPR unless you're certain the victim has recovered and breathing normally or a health professional tells you to stop. Moving on to choking, the rules are the same. Treat the victim who is choking by encouraging them to cough. If the victim deteriorates, give 5 back blows and followed by 5 abdominal thrusts. If the victim becomes unconscious, start CPR. The 2015 Advanced Life Support (ALS) guidelines have changed in emphasis aimed at improved care and implementation of these guidelines in order to improve patient outcomes. Increased emphasis on minimally interrupting high-quality compressions throughout any ALS intervention. This has also been reflected in the Basic Life Support guidelines.